Hi, I'm Dr. Darren Russell from Cairns Sexual Health Service in Australia and also from James Cook University. And I've been asked to talk today, quite an interesting topic. It's the integrated care and prevention for transgender men and women. When I was first asked to give this talk, I thought, oh, this will be pretty easy. I know a bit about this. And then I went and did a bit of a literature search and found there wasn't a lot that was really helpful to me on the topic. And then I panicked a bit, and then I realized, no, this is the kind of work that many of us do in our lives, our professional lives all the time. So I'm going to give you a bit of an idea of what this work entails, and hopefully you find it interesting. So when we're talking about integrated care and prevention, what does it actually mean? Well, I went back to the definitions. And integrated care, also known as integrated health or coordinated care, comprehensive care, seamless care, transmural care, lots of different words. It's a worldwide trend in healthcare reforms and new organisational arrangements focusing on more coordinated and integrated forms of care provision. And the World Health Organization gives the definition that it's a concept bringing together inputs, delivery, management, and organisation of services related to the diagnosis, treatment, care, rehab, and health promotion. So really a lot of words there, but basically the idea is to try and bring services together, bring teams together to deliver better care, better prevention. We're all aware, I think, those of us who work in healthcare, about the various silos that we have, and the lovely saying that silos are for farms, not healthcare, that many organisations work separately from other parts of the healthcare system. So primary care may sit outside a hospital, so that works by itself, and the rehabilitation section works somewhere else. Mental health may work somewhere else, so obstetric care works somewhere else. So there's all these silos that work separately, and especially for people with complex health needs, these don't always work the best. Lauren Sperling, who's a professor in preventive cardiology at Emory University in the US, says that the ideal model for healthcare would place the patient at the centre, with specialists in each necessary specialism sharing information and working together, perhaps under the overall management of a general practitioner to achieve optimal health outcomes. And I'll talk more about general practice as we go through, because I think it's got a lot of lessons for those of us who work in more specialised fields. Those of us who've worked in HIV for a long time, and you can tell by my lack of hair that I've been around a long time and working in HIV for over 30 years now, and I've seen a lot of things come and go. But HIV integrated care, I'm not talking about transgender individuals here, but just HIV care itself has been talking about integration for a very, very long time, really from some of the earliest days. And integrated HIV care can be defined as a care model in which specialists from multiple disciplines collaborate within a geographically and temporally constrained clinic environment to provide HIV-infected patients with on-site primary care, specialty services, and other services such as hepatitis C, mental health, substance abuse, social services, etc. And the little diagram there on the right, you can see, talks about some of these other things, with the person living with HIV at the centre. They've got their HIV, but they may have metabolic disease. And obviously in the last few years, this has become increasingly important in the field of HIV. Neurologic disease, arguably less important the last few years. Neoplasia, cardiac disease, renal disease. So all of these conditions sitting outside, and then broader aspects of the person's health, their mental health, their oral care, substance abuse, education, housing, employment, those social determinants of health as well, all designed to improve patient outcomes and improve the quality of life. So the integrated care for someone with HIV aims to bring all of these in together. There have been many different models of HIV care and prevention that have existed worldwide, and they've often changed over the decades, and I've certainly seen that in my 30 years of working in HIV. There are standalone HIV clinics, but other clinics have integrated with other services over the years. That hasn't always gone smoothly, particularly in the early days. Some services did not want to have people with HIV at their clinics. There was a lot of stigma then, and arguably there still is a lot of stigma. And that can be a problem, that you want to involve a cardiology team or a metabolic team or mental health or some other group. And if they don't know much about HIV, there can be stigma, which can be a real problem when you're trying to get better integrated care going. Early in the HIV epidemic, I certainly remember lots of presentations at conferences about the need for integrated care, particularly in the early days with tuberculosis clinics, that you had many parts of the world, particularly poorer countries, where there was a lot of tuberculosis, there was a lot of HIV, and they were treated separately at separate clinics, often miles apart from each other, which kind of made no sense at all from the patient perspective, from the health funding perspective, or from infection control perspectives. So the idea that you could integrate that and have the same group of people treating a person who has HIV and tuberculosis makes a lot of sense. We've seen this with sexually transmitted infections, and many sexual health clinics or STD clinics have been working with people with HIV and were really integral in getting HIV care off the ground, but were then able to provide prevention services and care for people who had STIs as well. Mental health we've seen, drug and alcohol, maternal child health, palliative care, all very important. But I think this slide here on the right, the box there, that only 49% of people living with HIV and TB are receiving treatment for both conditions, and this was from 2021 UNAIDS, really says how far we've still got to go in providing good integrated care. Modern integrated care for HIV can be provided in a lot of places. The hospital infectious diseases services or immunology clinics can provide this, metabolic clinics, and you've got people like Giuseppe Gareldi from Italy setting up great metabolic clinics for people with HIV and integrating that into their metabolic clinic setup and doing great work. Primary care general practice is very common, and HIV is often dealt with in that setting now more and more these days. It's become arguably easier to treat. Maybe group specific or condition specific. So you might be dealing with a group such as African American individuals or Indigenous people, or it might be condition specific. So you might be looking at a metabolic problem or cardiac or renal problem. In Australia, most of our HIV prevention and care occurs in general practices around the country and gives very good outcomes with a whole lot of benefits. And certainly over half the care for people living with HIV occurs in GPs in Australia. There's usually an ongoing doctor-patient relationship. You get holistic health care, preventive screening, care of comorbidities of HIV with a real understanding of those, and it's a one-stop shop. So I think this may be a very good model for integrated care. And in HIV prevention, of course, you see that provision of PrEP and other services is often integrated within sexual health or infectious diseases services. But again, we're seeing new changes occurring in the way that care is given. Standalone pop-up PrEP clinics are occurring around the world, services targeted specifically for gay men or for young people or African Americans or other groups within the community, for women, for example. And to me, they do seem centered more about populations, which makes sense because people going on to PrEP, by and large, are healthy people without health problems. So the integration occurs at the level of a population rather than a condition, which you might see for those who are living with HIV. There's also injectable and other long-acting PrEP that we're seeing now, and we don't quite know how that's going to evolve, but that may change the model that we're seeing. What about transgender care? I mean, that's what I'm here to talk about. So I've talked about integrated care for HIV, but what about transgender folk? What would that look like? On the left here, you see a number of disparate services, again, all sitting apart. But if you bring them under the one roof and you have, for example, mental health care, hormone treatment, surgery, aftercare, other services, all providing those services for transgender individuals, that's really what I'm talking about here with transgender integrated care. the provision of hormone treatment, perhaps mental health care, surgery or aftercare, HIV prevention and PrEP, HIV treatment, STI screening, possibly TB diagnosis and treatment in some parts of the world, reproductive health, so family planning and pregnancy care, primary care services, and nowadays, of course, COVID-19 prevention, so vaccination, or increasingly in the future, oral treatments for COVID-19 for the transgender population. These are some of the conditions or some of the things that we can talk about when we're talking about transgender integrated care. I think in many ways, a lot of transgender folk have just been a kind of afterthought for health services. It's like, oh, we don't really know what to do with our transgender individuals. We should try and set something up for them. So they haven't been front of mind over the past few decades, but increasingly are becoming so as the trans community demands that their health needs are better met. And going alongside this, I think in some parts of the world, the LGBT services that were often targeted, particularly to gay men, possibly lesbians, may be seeing fewer of those individuals because they're more mainstream these days, in some parts of the world, certainly. So you may have a decline in need for some of the gay and lesbian services because those individuals are moving to more mainstream settings where there's more acceptance nowadays. But that leaves a gap then, and that can be filled by the transgender individuals whose health needs are significant. The CDC, and this is a screenshot of the CDC HIV prevention and care for the transgender population webpage. So the CDC in America has very good information there about HIV prevention and care for the transgender population. So I'd really recommend, if you want to have a look at that, it's got some very good information, including some good tables on antiretroviral care and gender-affirming hormones, so estrogen, testosterone, testosterone blockers, and so on, and the drug-drug interactions and how they work together. I'm not going to go through all that, but very good information there if you're after specific stuff. There have been a lot of barriers to HIV care for transgender individuals, and a lot of trans people have experienced stigma and past negative experiences, discrimination, being called the wrong name or pronoun, being verbally harassed, being asked quite invasive questions, or even submitted to genital examinations and things like this. And for many trans people, their gender-affirming therapy is a much higher priority than their HIV treatment. They're more important for them that they continue their hormonal treatment. And there's certainly been a lot of adverse concerns rather about adverse interactions between antiretrovirals and GAH, which is gender-affirming hormones, so again, estrogen, testosterone, etc. And concerns are very common, and one study found 40% of trans women did not take their ARVs because of these concerns, so they do need to be addressed. There's some good examples around the world, and as this conference is in Bangkok, alas, I'm not, but hopefully later this year I can get to Bangkok. The wonderful Tangerine Clinic, which many of you will have heard of, and which I've had the pleasure of visiting, and it's just an amazing example of transgender integrated care, situated in central Bangkok. It's a transgender health clinic run by and for the transgender community. It offers sexual health, HIV prevention, HIV care, hormonal treatment. Then you've got in the US, Callan Lord in New York, their clinics in Chelsea, the Bronx and Brooklyn, LGBTQ healthcare, got sexual health, transgender health, dental, HIV prevention, HIV treatment, women's health, COVID-19. So wonderful examples of integrated care there. In Australia, we've got a couple of good examples. There are others as well. I just took these. One of them's a very good one. The other one's mine, but I thought I would share mine anyway. So we have the Equinox Clinic in Melbourne, which is a peer-led, trans and gender-diverse and non-binary health service, works in partnership with that community to provide a safe environment for gender-diverse clients to get good care. They do primary health care, so general practice, sexual health, hormone initiation and management, PrEP and counselling. So again, great services, and they're in central Melbourne. We're in Cairns. I live in Cairns, which is in the very top of Australia in the tropics. We have about 170,000 people in our city, but we have a big area of 250,000 people that we service. A large Indigenous, so our Aboriginal and Torres Strait Islander populations. It's a very big community, and quite a big HIV population and a transgender population as well. Our clinic does a lot of assessment and hormone prescribing for transgender adolescents and adults. We do sexual health screening, reproductive health, HIV PrEP, and HIV treatment. So once again, we offer our transgender individuals all these services under the one roof. And how do we do that? Well, there's multiple points of entry for trans people at our clinic. They may say, look, I would like hormonal treatment, and that's probably the most common. Or I need referral for gender-affirming surgery. We don't have that surgery available at our clinic, but we can refer to other places that do make that work available. I think I need counselling. We get that quite often. Someone would like to become pregnant. I think I'd like to have a child. How do I go about that? Or we get parents. I think my child is trans. So we have our counsellors who assist those parents. I need a sexual health checkup. Very common. We're a sexual health clinic, so that's our bread and butter. That's what we do. They may have symptoms of an STI and would like a checkup and see what's going on. They might want to commence PrEP for HIV, or they have HIV and are on HIV treatment. We don't have a very large population, not like parts of North America and Latin America with lots of co-infected trans women with HIV. We have relatively small numbers of those in Australia, but we certainly have some individuals who fit into that category. The picture here is of Raylene, one of our nurses with the trans flag there. All our staff are trained to deal with requests by transgender individuals. So our doctors, nurses, psychologists, a social worker, health promoter, our Aboriginal health workers, pharmacists, the admin team are all used to taking these requests, so people can be referred to us, or they can just walk in off the street, or they can ring up and we will try and slot them in and find a way to assist them with their care needs. So they may be transgender and wanting PrEP. They may be transgender with HIV and need their hormonal treatment and their HIV treatment. We try and manage all of that in-house, so the person doesn't have to go anywhere else. And I thought I should actually ask my patients. I was asked to give this talk. So as I've seen some of my HIV positive patients or PrEP patients or others coming through who are transgender, I've asked them, what about integrated care or the ability to have a lot of their healthcare needs met under the one roof? What do you think of that? And here's just some random quotes. One person said, I love that I can get everything done here. Another said, it's heaven having all my health needs met at the one clinic. Another said, you guys can prescribe my HIV treatments and my hormones, so I will feel really well looked after. Another older person said, I wish I'd found this kind of clinic when I was younger. It would have made my life a whole lot easier. Why don't you have this set up in every city? And there may well be in a lot of cities, but not everywhere. And some were really happy for the younger transgender people coming through that they could access such a service where their sexual health, HIV prevention, and transgender health needs are all met by the one team. I have put a little caveat down the bottom in the small writing. These are the patients who actually come to see me at the clinic. So there might be a whole lot of others who choose not to come and see me or not to come and see our clinic, and they don't like this model of care. But certainly for the ones who come to us, it seems to work. What are the advantages and disadvantages of integrated care? Well, I think greater patient satisfaction. I don't have any measurement of that, formal measurement, but it makes a lot of sense to me. I think we as clinicians, we doctors, nurses, others, we like to help people. And here we can help people. It's always so dispiriting if you see someone, you say, I can't do that. I have to send you across town to someone else who can do that. A holistic view of health. So we get that helicopter view of the person and all their health needs. I think there's fewer poor patient outcomes, fewer problems, fewer drug-drug interactions that may be missed, for example. Perhaps better screening of transgender individuals for various health needs, cancers, cardiovascular disease, etc. There's a reduction in transmission of infection, I think, by getting people onto PrEP or by testing and treating their syphilis, etc. We're primed to do that all the time. There are some disadvantages, obviously. You need a broader skill set to do a lot of this stuff. HIV doctors are happy writing HIV prescriptions, maybe less comfortable writing estrogen or testosterone prescriptions for their transgender clients. So they have to learn those skills. Perhaps there's a dilution of core skills. You know, my HIV skills could be diluted a bit because I'm doing all this work with transgender health. And maybe a lack of that super specialist skill. You know, you get those individuals in hospital clinics or elsewhere who are really very, very good at certain fields of HIV medicine. A greater workload potentially, and funding. You know, who's going to fund this if you're seeing more people for more things? Just want to give a bit of a case study of someone who came to see me very recently. I actually just saw her a week ago. I'll call her Fleur. She's a 57-year-old transgender woman. She was diagnosed with HIV back in '92, and she's had numerous antiretroviral combinations since then. She's been on a whole range of medications. She's currently undetectable on Simtusa, so that's darunavir, cobicistat, emtricitabine, and TAF. She takes estradiol, just a low dose, 2 milligrams a day, and soproterone acetate, which is an androgen blocker, just a quarter of a 50 milligram tablet daily, so 12.5 milligrams. She's in a rather, I've known Fleur for decades, and she's in a very unconventional relationship with Billy. He's an HIV negative cisgender man with significant mental health and drug and alcohol issues. And I don't believe they're sexually active at the moment, but they certainly have been in the past. He's a smoker, not Billy. Fleur is a smoker of 20 cigarettes a day, or has been, has hypertension, hyperlipidemia, but no interest in modifying her cardiovascular risk factors, no matter how much I bring them up. So in November, she had an acute myocardial infarction and was stented. She's continued her antiretrovirals and commenced on metoprolol, rosuvastatin, and prasugrel. The cardiologists wanted her to stop her estrogen because it was thrombogenic. However, being a transgender woman, Fleur was not at all happy with that suggestion, I can tell you. So they didn't know what to do, so they referred her back to me as her treating physician. I had a chat with Fleur. We continued her antiplatelet therapy and her estrogen therapy because it's so important to her. We reduced her rosuvastatin dose because there's a cobicistat interaction. We need to monitor her blood pressure because there's a metoprolol interaction with the estrogen. She did stop smoking, but last week she told me she's now smoking 4 or 5 cigarettes a day again. So I'm still unhappy with her doing that, but I'll have to keep working on that, I think. There are different service models. You know, you can see there with Fleur, all the work we've had to do. And there have been various people involved, the cardiologists as well, obviously, in that particular setting. So she's needed input from various settings. But having come back to us here at our clinic, we can deal with most of her problems in-house. I understand hormonal treatments. I understand antiretroviral treatments. I understand drug-drug interactions. I understand her need to remain undetectable, but also her need to remain on estrogen. I'm less good with cardiology. I don't understand antiplatelet therapy as well, but I understand it's important. And so as a result, we need to find a way to use all those drugs together. And this is where that integrated care works so well. In understanding her health needs and being able to deal with it. There are different service models. There's a micro-elimination model for HIV and Hep C, and I like that. And I think integrated trans care potentially could assist here. If you're trying to really reduce HIV levels in a broader community, then having integrated care for transgender individuals for their HIV prevention and HIV treatment, along with their hormone provision and other things, really servicing that transgender community may help you to achieve micro-elimination of HIV and, in fact, hepatitis C with the new direct-acting agents, sort of one bit at a time or one group at a time. The way, you know, here near my clinic, we've done a lot of work with the local prison and hepatitis C and cleared the prison of hepatitis C, an example of micro-elimination. And we've seen HIV hepatitis C co-infection eradicated in Australia, another example of micro-elimination. But I think having integrated care for transgender individuals, we can really try and reduce the HIV burden in the transgender community by offering integrated care. But how do we do that? Do we change an existing service? Do we add on something to the existing service? So you've got an HIV service, do you add a transgender service on? Or you've got a transgender health service, do you add an HIV prevention and care component on? Or do you build something new from scratch? Do you start a new clinic? Do you start a new tangerine clinic and set something up for a transgender community? So I suppose there's different models you can consider. And I don't know, but is there any way to have a virtual trans health clinic these days? Can we do a lot more of this via mobile phones and via computers and internet and be tech savvy so we don't need such a big geographic footprint? We don't need such a big building or clinic. Can we do some of this virtually? I would argue we probably can, and it might be an opportunity to look at this. Or can we link existing clinics? So we may have centres that are geographically separate or working differently somehow, but can they be linked to produce a new service by combining existing services? So it's just an idea. I don't know how we can do these things, but each country, each city will probably be a bit different. I think whatever we do, we need to design it with input from the transgender community. The meaningful involvement of people with HIV and AIDS, the MIPA principles are very important, and I would stress they exist for the transgender community. That old saying that we have, nothing about us without us. So I think if you're planning anything like this, involve your transgender community, involve your transgender patients in this, find out what they want, what will work for them, because they teach us how to do this. And I think the general practice model from Australia is very good. I alluded to that before, but our GPs do the majority of HIV care in Australia and the majority of transgender healthcare. So they're already offering those services under the one roof. So for our general practitioners, it's often no big leap to offer integrated care, and they arguably do it better than just about anyone. So I think that's a take-home message. That model from Australia probably works very well. So in summary, much of our medical work in HIV medicine and trans healthcare does currently exist in silos. Integrated care has many benefits for patients and the healthcare system. Good models of integrated care currently exist for transgender people, and the guidelines exist for co-prescribing antiretrovirals and gender-affirming hormones. Just go to the CDC website and look those up. But I'd ask you all to maybe consider how your service could offer integrated care to your trans patients. Maybe start small, see what you can do in terms of hormone prescribing for trans people who are requiring HIV prevention or HIV treatment, and see just what is possible. How can you help your transgender community to really be better informed about HIV and about their hormonal treatments and about interactions between them? And how can you reduce HIV transmissions within that community, possibly by offering integrated care? So thank you. That's all I have to say. You can see my team there on the right, quite a lot of them, dressed up in the colour purple, waving the LGBT and trans flags. All our staff try and be really inclusive and supportive of our trans individuals, both the young adolescents we see and the adults. And it's really wonderful to be able to work with such a team. So thank you for the kind invitation to have me talk. I've enjoyed putting this together. I've got my email address down there at the bottom, so if any of you would like to email me, please feel free to reach out. More than happy to talk to you, and I'm not sure I have all the answers, but I'm happy to go through some of the questions with you. So thank you.